Am I on now?
Bob, you're on.
Okay, thank you. I had a problem with my machine here. I'm really happy to introduce Jim. I've known him a long time, actually classmates back years ago, but Dr. deMaine has practiced pulmonary and critical care medicine in the Seattle area for more than 3 decades. And after graduating from the University of Pennsylvania Medical School, he served in the U.S. Public Health Service and was in the Peace Corps in Afghanistan. He's worked in the Committee on Ethics. He's been very active in the long term with as professor at Seattle, and he is now Professor of Medicine Emeritus at the University of Washington. He lives in Seattle with his wife and longtime best friend, Lourdes, in Seattle. And he also, just a couple things I would read about him, says he's interested in, excuse me, in aging and advocacy for those unable to speak for themselves, and the ethics of autonomy and how that plays out in nursing homes and assisted care, in creating systems to help the frail, elderly, and avoid necessary and unwanted interventions, and finding ways to document DNR wishes so that they are honored. He has been one of our most asked for presenters at the Boynton Beach retreat over the years. People want him back, and he has also, he'll tell you a little about it, I'm sure. He has a blog that is very interesting, and has recently put out the new book here, Facing Death, Finding Dignity and Hope and Healing at the End. It's very practical, but very interesting to read. So go for it, Jim.
Thank you very much, Bob and Tim and Foundation. I'm certainly honored to be invited, and certainly wish that I could ask the participants what their interests are in our medical choices about the end of life. So this is going to be a little shift in gear from Curtis and Jonathan, but there obviously is overlap in medicine because we're not just natural beings, but we're spiritual beings as well. And as we look at our choices, all of this is involved. So my hope in talking today is to get you thinking and talking and planning for the kind of care that you would want at the end of earthly life. I've always said dying is something we can't practice, that hopefully is only something we experience once, but it's still a mystery because the writings help us, but we still don't know. I have people tell me, listen, I'm not afraid of death. It's the dying that bothers me. So that will be more of what I'm talking about today, although I will touch on medical ethics and some of the choices that we make, which often are based on spiritual values as well. But I'd like to just start with a story, because I think in stories, and I've often found in the intensive care unit where I worked, that families would often relate better to stories than just a bunch of facts that are hard to put together. But I had a patient named Larry who had very advanced emphysema. I'd been in and out of the hospital several times, but I saw him frequently in the office. He was a nice guy. We always chatted. And one day he kind of surprised me. He said, hey, doc, I want to take you out to lunch. There's something that we need to talk about. I was a little nervous about that because he was a super salesman, and I was afraid that he was going to try to sell me something. And actually, in a way, he was. He wanted to talk to me about dying. And what he told me after we sat down and had some little conversation, he said, I want you to help me at the end. And I said, well, what do you mean? He said, well, when I get into the hospitalizations, I'm gasping like a fish out of water. I feel like I'm suffocating, feel like I'm drowning. This terrible panic situation sets in, and I know I don't have long to live, but I want some help at the end. So we talked some more about that, and I said, well, I'm not Dr. Kevorkian, but there are things that we can do at the end that now we would call aggressive palliative care. And that was a field that didn't exist when Larry and I had that conversation. So I said, well, the one drug that would help you most at the end is morphine. He said, well, what would that do? And I said, well, it would sedate you, it would make you sleepy, give you a sense of euphoria, it would take away your sense of suffocation and shortness of breath and give you peace. And he said, well, that's what I want. And I said, well, there's a downside to this. When you take morphine, it could speed up your death. It could hasten your death by a matter of hours or even days. He said, that's not my concern. He said, my quality of life is so poor. I can't go out and dig clams anymore. I can't go out crabbing. I can't have any fun. And he was living alone. So I said, well, why don't you move into Seattle? Because he was out on one of the nearby islands. And he said no, and he didn't want to get help in. So I said, well, you better talk to your two sons, see if they're on board with this plan, because I think I can go along with your wishes. So he did and touched base. So this plan was in place. Nothing much happened, but in the dark Christmas season around Seattle, over dinner time, I got a call at home that he was in the emergency room, gasping, terribly short of breath. And they wanted to put him on a ventilator, put him in the intensive care unit. And I said, I'm not sure that's what he wants. Let me come in and see him. So I did. And he looked me in the eye and he was able to say, remember what we talked about. So I reviewed the plan with him. Sons were there. And we did not admit him to the intensive care unit. We put him up in a medical care unit. Fortunately, there were senior nurses there who were very experienced and caring. And we started IV, we started giving him small doses of morphine, made him peaceful. And the nurses said to me, thank goodness, doctor, you can handle a situation like this, because we don't want to have to do CPR, cardiopulmonary resuscitation, or put a patient like this on a ventilator when he's near life's end. So after about several hours, about 3 or 4 in the morning, he passed away peacefully. And later I got a beautiful note from the sons that said, Dad got exactly what he wanted. His autonomy was respected. He was able to get what he wanted. And if he could come back now, he would shake your hand. And that's one of the many kind notes that I've saved from patients over the years. And ethically, it raises a couple of issues. In ethics, we talk about autonomy. What does he have a right to ask for? And certainly he had a right to ask for this. And on my end, my intent was to relieve his suffering. My intent was not to hasten his death. And that in medicine and ethics is what we call the double effect. It was allowable to do that if my intent was a caring one of relieving his suffering. Some people say, well, that's splitting hairs, but it's been tested in court. The major medical societies support the concept. A friend of mine gave me a book on theological bioethics from the Catholic point of view, and the Catholic Church accepts it. So it's something that now is ingrained in our culture and acceptable. So I think at this point, what I'd like to do is show you some slides and walk you through some of my thoughts about advanced care planning and how we might make our thoughts known to our own medical providers as we age and as we develop illness. So here we go. So as Bob mentioned, that's the title of my book. And after hearing Curtis this morning, I think Jonathan and Curtis should sign up to be my publicist for the book, but that is not likely to happen. This is a very kind of natural, practical book, although it does have spiritual elements and I do have stories about spirituality and end of life care. In the Atlantic several years ago, it pointed out that we are aging as a society. I was afraid when I looked at this picture that the guy was a little crazy, that he was about to fall and break his hip and wind up in the hospital, possibly with a head injury as well. These are not uncommon things that we see in seniors that are maybe a little overactive and falling and not careful. But another article, by the way, in this article, it talks about living to be 100. And a child that is born today has a fairly good chance of living to 100. So there's a shift in our society. We have what's called the silver tsunami, kind of an aging population bolus that's coming through and is requiring a lot more attention, a lot more care. But also in this particular magazine, there's an article by Ezekiel Emanuel called Why I Want to Die at 75. And he felt life was completed by the time you're 75, that he would not even take an antibiotic, that it was time to move on. I think he was doing this somewhat tongue in cheek, but I do have a chapter in my book trying to rebut this idea because it is ageism. I think there is a lot we still can contribute. I actually was able to write my book at age 81 with a lot of loving help from my wife, Lourdes, of course. So William Saroyan says, everybody has to die, but I always believe an exception would be made in my case. And, you know, that's okay. I think as we go about our day-to-day life, we're in denial. A denial can be healthy because it shouldn't consume our thoughts that someday we're going to die, but we need to acknowledge it's there. And every once in a while, we need to take time out and pay attention to that fact. And as we get very sick toward the latter part of our lives, about half of us can't make health decisions on our own. And this is where we really need an advocate, somebody close to our heart. And I'll be talking more about that as we move along. So when we do talk to our advocate, we do talk to others, how are they going to know what our wishes are? Because we aren't the same. We will all have a different approach. We will all die in our own unique way, just like we will enter the spiritual world in our own unique way. There are some good resources about end-of-life planning, and these are websites. You just type in Prepare for Your Care, Google that, or My Directives, or the Conversation Project. This was started by Pulitzer Prize winner Ellen Goodman when her mother had what she would call a bad death. Things were not handled well, it was chaotic. So she's put together a project about how to get that conversation going with your family. And all three of these sites have all the directives and forms and videos, starter kits, that kind of thing that you might need. And you can write an essay or a letter and include your spiritual values. These can be attached to your advanced directives. My nephew Steve David sent me this number from Heaven and Hell from this New Christian Bible Study site. And that's cross-referenced in multiple ways there. But it is just one number that you might think of, but there are so many others, or just what's so important to you in terms of interacting with your loved ones. And then you can attach these to your advanced directives, put them all together. Give copies to your family, your attorney, your healthcare team. They need to know you as a person, because when I was in the intensive care unit, I would be talking to your loved ones and you can't participate in the conversation. So the more that I would know about you as your physician, the better. And make sure these documents can be found. Where I live, we store them in a plastic folder underneath the kitchen sink. You can put your medical information, your meds, your insurance information, your directives, your pulse, your most form. I'll talk about that a little bit later. And this is Velcro. It can actually be pulled off if 911 is there and be transported with you if that's necessary. But it's important that these documents, they're no good if they can't be found. And so if you want them, make sure your loved ones know where they are. It's no good in a safe deposit box. If it's in the freezer, it might be under the food. So this is what we decided to do, and it's standardized for the whole building where I live. So you need to ask yourself, okay, what is an acceptable quality of life? Ask yourself, if you're seriously ill, what makes life worth living for you? You know, how much time do you think you have left? Let's say you've had a severe stroke, or you're paralyzed, or you have a life-threatening cancer. Are there things that are really keeping you going, or do you feel kind of ready to go? Given the nature of your illness, what are the most important things for you to achieve? I had a 17-year-old young woman that I write about in my book who had severe cystic fibrosis, which was approaching end stage. She was a lovely young girl, wanted to be a nurse, was excelling in high school, but had had several hospitalizations and her lungs were failing, which is sad because now there are some very significant treatments available for cystic fibrosis, but in those days there weren't. So she got acutely ill. One evening, 911 was called. She was not breathing well at home, so they put down an endotracheal tube into her airway and transported her to the hospital. And so I became her attending in the intensive care unit. And it was a sad situation because we knew that she would never make it off the ventilator. And I had a colleague from the University of Washington come over, and he had been seeing her in the adult cystic fibrosis clinic. And we met with the family, and her mother had a difficult time with this. The father had not lasted the illness, and there had been a divorce, so it was added stress to the family. But her mother said, you know, the most important thing to her a few weeks ago was to go to her senior prom. And that was what her goal in life was. And I had to really struggle to figure out whether to allow her to go or not. But we decided that's what she wanted, even though there was risk. And I feel badly about that, but there's some comfort knowing that she got to do what the thing that was most important to her. So the following day was her birthday. They decided not to remove the ventilator on that day, but the following day, family was there. We gave her very heavy sedation, turned off all the monitors. Family stepped out while I removed the endotracheal tube. Then the family came back in, and we made it as, in quotes, home-like death as possible with the loved ones close and holding her. So each of us has our goals. Each of us has the things that are important. So what are your biggest hopes and what are your biggest fears? I was asked in an NPR radio interview several years ago, Dr. DeMay, what is a good death? And I thought, well, isn't that kind of an oxymoron? But I think we're really talking about a good dying process. And I've given some thought to this over the years, mainly from patients, what patients have told me. One is pain and symptom management. I think shortness of breath, nausea, or whatever is bothering you, they are all important to get under control. And what are our wishes? Are they honored? Are we truly understood and listened to? And have we had a preparation for death? Have we had a chance to think about it, make amends, have the conversations, both spiritual and natural preparation? Have we been able to complete goals, whatever we had set out? Maybe yes, maybe no, but at least maybe we've made a good try. And have we contributed to others? Have we been able to leave a legacy? I think that sense of completion at that time is important to so many people. And then lastly, I think what we would all want to be in a peaceful situation, hopefully a home-like environment surrounded by loved ones. Now, the causes of death, some of them are actually improving, like some of the cancers. You can see here heart disease, and HIV has dropped. But death rates, unfortunately, for Alzheimer's, which we don't have really good drugs for or don't have good prevention, but believe me, that will come. There's articles in the paper almost daily about potential new drugs. But I think it was mentioned earlier, we've had an extremely tough year. And this is from early 2001, where COVID-19 was the leading cause of daily deaths, followed by heart disease and cancer. This 3,000 figure now has dropped down, and I think most people would now say that COVID-19 is the third leading cause of death. But over 500,000 deaths have really struck our society and caused kind of a national change in our psyche. We're thinking about ventilators. We're thinking about stress on our schools and our healthcare systems and our frontline providers. So it's been a psychological impact, and maybe some good will come of this as we begin to think about our own death and what that means for ourselves. For people that are in denial, I like to show this slide. It comes from the humor magazine, The Onion, and it shows the world mortality rate is holding steady at 100%. Somebody asked me if I would update the slide. I really don't think I need to. So how about our modern dying? Where are we dying? Are we still all going to the hospital to die or not? And it's interesting that only about 20% of us now die in a hospital. More and more we are in a home, or, of course, possibility of a nursing home or assisted care, some kind of long-term care facility. And hospice is being much more used than it has in the past. Often not as early as it should be, but I think it's gained traction over the years, and we have more hospice use than any other developed country. However, the glass is half empty in this portion because 66% of us are hospitalized in the last 3 months. It may mean, I mean, some of these are necessary, but some aren't. We're in that dying process, and do we really need to go to the hospital? Do we really need to be placed in the intensive care unit? We have a lot of technology, we have a lot of things we can do, but do we really want that? And that's where these conversations are so important, so people understand our values. And unfortunately, 33% of us are in the intensive care unit in our last 30 days. Again, some of that is necessary, but some isn't. We're still much higher than most countries in these last two. So somebody asked a philosopher how he would like to do, and he said how he would like to die. And he said, when I least expect it, what else? I mean, that's okay for us, but it's very hard on those around us. And most of us, in fact, do not die from a sudden event these days. Actually, 911 responses are much less now to heart attacks than they are to other medical emergencies. And if you have something like certain cancers or some cases of Alzheimer's, there's a fairly predictable steady decline. And then if you have a chronic illness like heart disease or emphysema, there is more of a slow decline, somewhat like this, where we start with a certain level of health, then there's a flare-up, and then you get treated and you get back to normal, and then there's more flare-ups over time until you finally get down to this level. Are you going to go to the intensive care unit here? Are you going to be placed on a ventilator? Or, as the Tokurunde says, and I hope you've all read his book, Being Mortal, it's time to let go. Is there a time that we could say enough is enough? It's time to peacefully transition out of earthly life. It's an existential question because you've gone from full treatment mode, do everything, to what we call a comfort mode, where you say, just keep me comfortable. And that is never an easy decision for the patient, for the family, or the medical provider. And it's an area of potential disagreement from time to time. But this is where we need to listen. Providers need to listen. Families need to listen. What would your loved one want? In the intensive care unit, I so often saw families that had never had that conversation. And so their loved ones were struggling. What would they want? And so we would gather in a family conference, we'd talk about the life of the individual, and then we'd try to come to what we call shared decision making. Would they want more treatments? Would they want another chemotherapy? Would they want to keep going on the ventilator? And then try to come to consensus and hopefully get it right, but we were never completely sure because that important conversation had never been documented. So most Americans live long lives with an increasing burden of medical problems, but eventually, at some point, we become very sick before we die. And there's kind of three general pathways we need to think of. Now, for the younger, healthier person that has an acute event, we're going to opt for life-prolonging care. And actually, if you don't make your wishes known otherwise, society is geared. If you go down at your local Safeway or your local grocery store or your sporting venue, wherever you happen to be, and there's a bystander that's trained in CPR and they have an automatic defibrillator, that's what they will do. So you have to, we're all signed up for that. That's a society permission for a stranger to actually perform very vigorous medical care retrieval for you. It's an interesting societal norm that we've established. When I was in medical school, none of this existed, so it's come on over time. Now, there's a second choice we can make. Let's say we don't want a ventilator or we don't want CPR. We can make choices of, yeah, I would be willing to have a feeding tube put in, or I would be willing to have IVs, or I'd be willing to have antibiotics. Or let's say you're even sicker than that and you have a stage 4 cancer and your health is failing. Then you can elect for comfort care. And we're much better at that now. I'll talk a little bit more about hospice and palliative care. Now, how about CPR? You know, if you watch television, 66 out of 100 people survive CPR. And that is, believe me, Hollywood. If you look at the overall population survival from CPR, it's about 15 out of 100 people. And then if you look at aging and more frail people, and I'm beginning to qualify for that, less than 5 out of 100 people, less than a 5% survival. And some of those 5% survive, have brain damage, or never make it out of a nursing home. So at some point, we have to decide, do we want to have CPR or do we want to have more selective care? And if you have a very advanced cancer, your chance of survival is approaching 0. And that's a situation where sometimes the nurses were put in that situation where they had to do CPR because the patient insisted that everything be done. And that's where you get into the ethics of end-of-life care. There is a concept called futility, but can the medical provider in a paternalistic or beneficent way saying, we are not going to provide that, or can the patient demand it? And there's friends of mine that deal in palliative care have a way of approaching that more directly to a family. They're saying, we are not going to provide CPR for your loved one because they would not survive and would not benefit them. And that's what they call informed assent rather than informed consent. So we're learning better how to talk, how to advise, and how to listen. It's a process, but I think medical education is getting better along those lines than we used to be. So even if we don't want a resuscitation, you might get a pneumonia. And I remember I had a patient in my office with a significant emphysema, but he was functioning pretty well. And he looked me in the eye and he said, "Hey, doc, listen, at the end, no tubes. I don't want any tubes." And I said, "Well, Harmon, what if you got a pneumonia and you weren't breathing well? And I was giving you antibiotics, but you still weren't breathing well. But if I put you on a ventilator and put a tube down, within a week or two, your pneumonia would likely clear and you'd have a good chance of making it and getting back to the way you are now if we use the ventilator." And he said, "Well, of course I'd want that." So you need to have that conversation. It needs to be detailed. People need to have informed consent about the treatments that are available and what the pros and cons are. And most of us never have that informed consent discussion because it's a once in a lifetime event that we don't think about much. So with selective care, we can think about fluids, or we can ask that fluids be withheld. When my lovely father was passing away slowly in a nursing home in Western Pennsylvania, at the end, he kind of quit eating, and then he quit drinking. And he had said ahead of time that he didn't want anything, in quotes, heroic done. And I think he meant fluids and IVs and that kind of thing. So basically, he just slipped into coma. He was given small doses of morphine. We were able to set up a bridge table in his room. Family members came in to say their goodbyes. And basically, over about 5 days without fluid, he passed away in a very, very peaceful, normal way. And that was his wish. We had one friend who said, "What? You didn't give him fluid, you give him nutrition. You're just going to take those old people out there and let them die?" And I said, "Well, that's not what he wanted." He said, "Well, there's a culture of death in our society." And I said, "That's not the situation here. We're all going to die. Dad got to choose the way that he was going to be treated at the end." Another thing that we're not doing anymore, we're trying not to do, is tube feeding in dementia patients, because it just does not work, and they survive better and do better with just careful spoon feeding. Antibiotics, should we use an antibiotic or not? In a Seattle nursing home, a friend of mine did a survey of physicians saying, "Okay, you've got a lady with advanced dementia. She's been bedridden for a year. She doesn't recognize her family anymore. And she's been ready to go. But you're called one night. She's got a temperature of 104. It's probably a bladder infection that's ascended into the kidneys and now the bloodstream. Would you use an antibiotic?" And about 80% of the doctors said, if she's at the end of her life, and she's not in pain from the kidney itself, they would not give an antibiotic. They would let her pass away normally. So again, there's this, okay, when do we let go? When do we quit using the modern medications and technology we have? Never an easy discussion. So comfort care, it is not a new concept, but a really old concept. How do we bring comfort to the dying person? And obviously we need spiritual comfort, and we need creature comfort, natural comfort. And the things we need to focus on is general well-being and the need for symptom control. And both palliative care and hospice can provide these and help to achieve these goals. One thing we should never say, and I'm talking to physicians here or nurses, and I'm sure they'll agree with this, we never say that there's nothing more we can do. Because even if you're DNR, do not resuscitate, or no feeding tube, it never means no care, because care is always possible. We need to be a caring profession. Humanity needs to be caring, even if cure is not. I'm sure you're all familiar with hospice. I won't go into detail about that, but one plea I have is if you're thinking about hospice, think about it early. Call them, call your local hospice, have a conversation, talk to your doctor, get a referral early. They want to get to know you. They can help in so many ways. And it's nice to see that this is an expanding service. It is mainly done in the home, although there are respite inpatient units, and it is a Medicare benefit that brings a lot of material benefits and support that you would otherwise not have. And the surgeon told me, he said, listen, dying without hospice is like having surgery without anesthesia. So we do need that help. Palliative care is a new specialty. There'll never be enough of them. It's something that general internists, hospitalists, family physicians all need to learn. But the focus on palliative care is not on your organ that's sick or on your cancer or on your particular diagnosis. The focus is on you as an individual, a very holistic approach. In what way are you suffering? In what way can we coordinate your care, bring the specialists together, have a clear care plan to address whatever symptoms you have? And it provides guidance to your healthcare team. It is now a specialty, and if you're hospitalized and things are confusing and you're conflicting advice from specialists, ask to see a palliative care doctor. And unfortunately, we need them because about half of us are troubled by moderate to severe pain or other symptoms during the last months of our life. Never said that dying is easy, but it certainly can be moderated and controlled. Let's not delay hospice. Let's use it when we need it. So who's going to speak for you if you can't speak for yourself? I want to show you a short video about how to or how not to choose a power of attorney for healthcare.
Jim, I don't think we have audio on this. We could
Okay.
might check your setting.
I'll skip that. I guess you weren't getting audio. The point of in choosing a durable power of attorney for healthcare is to choose somebody really close to your heart, somebody that can stand up to providers, somebody that can advocate so well for you. For example, I actually had a physician that I was caring for with emphysema who was admitted to the hospital. I happened to be out of town and my colleague was there. This physician, my friend, did not want ever to go on a ventilator. He wanted to die naturally. But my colleague saw him and his wife in his room and said, you know, if I put you on a ventilator, I can kind of get you through this episode. And he kept saying, the wife said, well, you know, he really doesn't want that. And my colleague said, well, you need to reconsider that. And she kept pushing back. And as a strong advocate, she basically asked him to leave the room. So sometimes you have to be strong and find the right person. And it's not an easy job. And you need to have that in-depth conversation. I won't go into this because we're going to get a little time limited here, but if you have a severe life-threatening, life-limiting illness, consider the physician orders for life-sustaining treatment, also in some states called medical orders for life-sustaining treatment. This is what I call a 911 form. It's one I showed earlier. It can be stored somewhere in your home. And when the medics see this, they will know right away whether you want life support, whether you want CPR or whether you don't want CPR, whether you want a ventilator, whether you don't want a ventilator, because they only have a minute or less to make that decision. And if you've been able to tell them by this form then they will adhere to it. They love to see it because they don't want to perform CPR on somebody dying from cancer that's in their final stages. So if you call 911, this form helps so much. It helps guide the care until you get to the hospital emergency room. The issues with advanced directives, there can be problems in finding them. And unfortunately, at times they may not be followed. Sometimes you need your advocate there to reinforce them. They need to be updated, looked at periodically, and certainly they can't cover all situations. It'd be nice if they could, but it is a form, and I think we can over-rely on forms. That's when we need to turn to your durable power of attorney for healthcare. And the ethical principles I mentioned can be difficult to apply in specific situations. And I'd like to take the last few minutes, maybe giving a future project for Jonathan Curtis, I don't know. But in medical ethics, a very important one is do no harm, primum non nocere. And Jonathan, yes, I did take Latin, 2 years in college actually. But what would Swedenborg say? Shun evils as sins. Okay, how do these two correlate? It's up to us to think about. This is worth another session in itself. And then I mentioned autonomy. Do we always have the right to make a decision? This is flared up, of course, in a death with dignity, or do we have the right for medical assistance in dying, so-called physician-assisted suicide? Yes or no? Well, do we have that autonomy? I think in the writings we would call it as of self. Well, what do we mean about that in terms of bioethics? Because the Lord gives us a strong sense of self, but it really comes from the Lord. It doesn't come from us. And beneficence, doing good. Sometimes, somebody once told me, beware of the person that tries to help. So we have to make sure that the person wants the help, accepts the help, and that we're doing it from the right motive. So usefulness from good and truth. These are all within the in the whole field of ethics. And then justice. We're seeing justice in terms of how do we allocate the vaccine, who should be wearing masks. They're very practical bioethical things. Can a laboratory take your DNA and sell it to a drug company without your knowing? All these kinds of things. That gets into do no harm autonomy, and where they might think they're doing the right thing, but they are infringing on your autonomy. So there's a lot of push and pull between ethical principles. And then one I like the most is kindness, and for what's called virtue ethics. That is now making its way into medicine, believe it or not. There's actually a book written now about compassion. And one reason I think that it's happening more in medicine is because we have so many more women doctors. There's a real strong feminine approach to listening and kindness that has been somewhat, not universally, but somewhat missing. And I think the writings would call it loving the neighbor. And this is a quote from the Heavenly City. A life of kindness is the primary meaning of divine worship. Really something to ponder. So for more, please have continuing conversations with your advocate. There are 10 top books on advanced care planning in the Conversation Project. And then you can take a look at my blog that I've been doing for years, endoflifeblog.com. And it's mentioned, this is a book of stories. It's not, it has a book about medical ethics, got some spiritual components, some mention of Swedenborg, but it's not what I would call a spiritual book. It's more a book of lessons for us to learn as we approach dying. And Peanut said it's a beautiful little tree. Yes, it is. Shame we won't be around to see it when it's fully grown. And Linus said, why? Where are we going? And of course, we want an answer to that question. Then we turn back to what the Swedenborg Foundation is doing. So thank you so much. I would appreciate any questions. I don't know if I've left enough time for any.
Jim, we do have a few questions I'm gonna pose. So,
Okay.
great. So, I'm going to read off a few of these. I do have a question myself that I wanted to make mention, and that even though we are recording this and we'll send out the link, is there another way that somebody may be able to gain access to that invaluable information that you had in the slideshow?
Yeah, I will. I'll take what I've done and put it up on my blog. That's probably the easiest way to do it. If you don't remember the address to my blog, you can go on the Amazon site and click on the author page, and that will take you to my blog post as well. So, and then also I have an index in the back of my book that references these websites. So that may be useful as well.
Great, wonderful, thank you. We have a couple more questions. Julie has asked this question. I was a hospice chaplain for around 10 years. There are certainly many issues around dying, which is why I am such an advocate for hospice. Making people comfy at the end of life is much kinder than putting them through ventilators, etc., drawing out the dying process. I guess that's more of a statement than a question.
Yeah,
but
well, yeah, just to reiterate, I practiced medicine before we had hospice. And when I would discharge patients from the hospital, they felt abandoned. This is a way of keeping a close connection. I had one lady with, it's a story in a book, with primary pulmonary hypertension who elected hospice instead of a lung transplant. And the hospice nurse kept sending me notes, but one day I got a request to visit her home. And so after work, I knocked on the door, and she was from Guam, very loving, very Catholic family, excuse me, and a grandchild answered the door, and I heard music coming from inside. And the child ran and got grandpa, and they ushered me in, and there was food abounding all over the dining room table. Music was playing, kids were running around, and there was her bed right in the middle of all this. She had a sleepy look on her face. She was able to do little doses of morphine. And I just sat with her for a while. And I thought, what a peaceful way to go. What a caring way to go. And I think in a way, I call that a healing death. It's healing for her loved ones and healing for her caregivers, that they have this positive memory of that legacy that is left.
wonderful. Another question from Zach. Elizabeth Kubler-Ross mentioned in one of her books that everyone at the end of life wants love more than anything else. What would you say? Would you say this to be true?
Yeah, my father used to say the answer to everything is LOVE. He was talking about marriage relationships and everything else. But yeah, I think seeing in the COVID epidemic, the isolation that people have had, and then the mental deterioration that has accompanied that, particularly in nursing homes. We've seen our chaplain where I live connect people by phone or by Zoom who are isolated. And when you're dying, you're in a very isolated place. You're in a transitioning place. So I think, before we're ushered out of our body, to have that sense of love and loved ones around us is so important.
Well, thank you so much. And the final question comes from Kay. Kay asks, how do you find a doctor in your local area who is like Dr. deMaine, one who really helps you with this kind of decision making? Do you have any relatives that live in that area?
I think we went through that whole thing of trying to find somebody. I think looking at, everybody's got most organizations have their doctors on a website and they'll put up something positive. But if you can see maybe a little bit about their interests, their education, maybe any special training they took. Like the doc I had he's an internist, but he also went and got a master's in public health and nutrition. And I thought, this guy's interesting. And then then talk to friends. That's kind of what you have to do. Who's caring? Who's a good listener? And medicine has changed so much. We have so many more women in medicine. So I think women have more choices and better choices now than they used to have in terms of connecting.
Very nice. I appreciate your responses. Those are the extent of the questions we have right now. I will encourage, if you have additional questions, we'll capture them in the chat, the Q&A portion, and we'll make sure that we forward them to Dr. deMaine, and I would imagine he'd be able to then respond to you directly.
Yeah, glad to.
Thank you so much, Doctor, for your time and your presentation. It was fascinating information. I was taking notes feverishly when I got writer's cramp. But I look forward to seeing the presentation itself then. Thank you so much. Further ado, I would like to welcome back our